Just keep it going here. 7:31. We'll go back to the KUAM News Zoom room where we have from the Department of Public Health and Social Services the medical director, Dr. Janna Manglona, and the contact trace lead, Annette Aguon. Good morning, ladies.
Good morning.
And
Good morning.
Okay, good. Yeah. Doc.
Can we hear Dr. Janna?
Oh, Lordy. Here we go, Doc.
Oh.
Totally didn't see that coming.
She's been in the Zoom room for a half hour waiting to break that one.
All right, man.
Well played.
Ooh. Good times. Welcome back, Doc.
Hey, there isn't a tape strong enough to keep my pie hole
Yeah.
shut.
Pie hole. I don't think you can say that.
Oh my God.
We're
I can say that.
Yeah, you can say pie hole. Say it more.
No, well, you know what? We have a segment on the show that we put out on Facebook called "In Case You Missed It."
Yeah.
I think we just found our segment for today.
Oh, I don't know how to follow that. Go ahead, Bree.
No, I'm just like, wow, I don't think I've ever seen you with your hair down. That's nice.
Oh, yeah. Yeah.
I used to before COVID.
Yeah.
But I just throw it up. It's fast, and
Right.
I was up till midnight, just with conference, and then through the night, GMH calling. You know, it's pretty steady through the night, so
Right.
I haven't had time to put it up yet.
Well, I was a little distracted by the tape over your mouth. Notice your hair. Okay.
You look good. You look good.
Yeah, good. Hi, Annette. Hey, Annette.
Hi, good morning.
Good morning.
Morning, Nettie.
Let's just get right
Good
into
morning,
it
Dr. Janna.
with what Dr. Ho had said, and we'll just start with Annette. And is that accurate? So the 43 positives we reported last night, 37 were found out through contact tracing done by public health.
35 are contacts and 2 were through travel related. So the other cases, is preliminary. We have to verify if there's any links to known cases, or if there be it household or community contact. So those investigations, there are times where we find out the link, after the cases are reported to us, and we look backward to where they know, and places they've been to and where they work, and so that's where sometimes we connect the dots after the fact.
Could you give us any more of a breakdown on so we had 35 contacts to known positives. Were these from what types of gatherings, or, from where?
We've seen a lot, unfortunately, household members, where one individual became sick, and then unfortunately went on to other family members, be it the spouse or the children. We do have a few who are community contacts, mainly like they were coworkers. They brought it home to their family, and then unfortunately spread it to their family as well.
And we have had some that I don't have numbers, but of the ones in quarantine, we've had some of those turn positive too. The ones that were taken from the flights, we've had positive cases from there as well. Which is good, because they didn't, no big deal, because we didn't let them out in the community. So those were contained.
So were these positives that they turned, what, because I think you said turned positive, was it on their first test in quarantine? At which day mark?
Some came in negative and turned positive on the retest in quarantine.
So on that note, let me ask you, because I know that we had just we were doing a test program for allowing people in quarantine who test negative to go attend funerals, and I stumbled onto the scene. We did a whole story on it, and at the time the issue that I had that we weren't able to really communicate was that you're right, people test negative and then a couple days later they test positive. So there's that window where you might be negative and you're going off to your relative's funeral, but you're really positive. Have we scrapped that whole pilot program?
We've closed that gap. If you leave quarantine, it's with a negative test.
Okay.
Meaning, if you want to go somewhere, you're going to be tested.
Right there.
And if it's negative, then you can move on, by and large. And those are special situations. And I wanted to emphasize that too. Although it looks fairly rigid, we follow a protocol, but there's always room for extenuating circumstances. So, we come into we run into those, and we do workarounds for those. So, don't hesitate to ask if there's something compelling and you're in quarantine. We follow protocol, but there's always room to ask if you have some need. So I wanted to get that out there too. And we run into that frequently.
Doc, I wanted to ask about this argument that I see on social media, and I've got my own opinion on it, but it's with the classification of these deaths as COVID-19 or COVID-19 related. Just from the medical standpoint, can you kind of go into the whole process? Because, and I've talked to a bunch of doctors, and I know we're following the same process that everywhere else is following. But if you could explain why it is, for those people out there who don't understand or, want a better idea, why is it that when we have these patients with the pre-existing comorbidities and they get, they test positive for COVID and they die, we classify it as a COVID-19 related fatality? So I guess just go through what the virus does, how it accelerates death, from a medical standpoint.
Comorbidities in general impact your immune system, and that's the only thing you've got to fight the virus. So if the only tool you have is impaired, then you're not going into battle with a full armamentarium. You want to go in with everything intact to fight this thing. And some have no symptoms, but some really take a hit. And I heard Dr. Nguyen talking about how fast people turn. I can tell you this: last night, or maybe it was 2 nights ago, I had a patient that was evaluated, young person, evaluated at GMH. He was in isolation, wasn't doing well. We transferred him out. He was evaluated. And at the time the report was given to me by the physician, everything was stable as it could be. And he was eating, doing fine. In the drive to the isolation facility, by the time he arrived, he was unstable. His oxygen had dropped. He was short of breath and had to completely turn around and go right back to the hospital. So that's how fast. And I've seen online where with most illnesses in the hospital, if people are improving, it's usually a steady trajectory to discharge. They get better, better, better. With this one, people can be better, 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 and then crash. And that is not something we usually see. And Dr. Aguon will tell you that too. She says usually by day 5 or 6, but I read a blog online where a gentleman said, I was doing fine for 4 days. All I know is I awakened on day 7 and I was being extubated. They were pulling the tube out. He had been on the life support for a couple of days and didn't even know it.
Mm-hmm. Do you have any?
So it's go ahead.
No, I was going to say, do you have any information on like the length of stay for a COVID patient at the Guam Memorial Hospital?
Oh, that
like
varies.
Estimated.
It's not there. An average wouldn't even mean anything because some people have been in there for 40 days, 30 days. Some are in 1 day, and it's all over the place. It just depends. The critical care. I think Dr. Nguyen mentioned that they're 100% COVID right now, and they have 53 in the hospital. 11 of them are on the ventilator, 14 are critical. And early on, the death rate for ventilator patients was around 80%. And some of the newer data, I'm not going to say studies, but the newer data is showing that it's hitting around 36%, which is still not good, but better than 80%. So 4 to 5 out of 10 may not make it off the vent. So it's very serious. And I wanted to emphasize that even if you're in a low risk group, you may pass it to someone who is in a high risk group and they may not survive it when you have little or no symptoms. So, we've got to really emphasize what he said too. Please take care of the elderly and the sick and the obese. There was an article in Washington Post today that people under age 60 who are obese are more likely to be hospitalized, end up in the ICU, and die. And we can't say that for many other illnesses, but this one, yes. So that was just out of the post today.
Wow.
So also, I want to emphasize this. Sorry, Nettie, but I'm on my soapbox again. We've had several. That arrived in either dead on arrival or nearly dead on arrival, which tells us that those people have been sick for at least a day or 2 days, maybe more. If it's that fast, maybe they didn't have any notice. But we just want to emphasize that you get help early. Seek help earlier. It's much easier to treat the earlier you get to the hospital or the earlier you get to your clinic, and we can identify the problem. So don't wait. Don't wait till it's too late. So please go early and report early for evaluation.
That's very key, Doc. Annette, let me ask you to kind of bounce off what Doc Manglona just said. So when someone does show up at GMH, dead on arrival, near dead, test positive for COVID, can you explain the process of the public health contact tracing from that point? Because then you guys would have to work backwards, because like Doc Manglona said, if these people were already sick, I'm only assuming they were coming into contact with, all sorts of people.
Annette can answer that one.
Right.
Yes, we would still initiate the case investigation and contact tracing. There have been some instances where the individual had already tested positive and was brought into GMH as a known positive, and so those case investigations had already been initiated. Contact tracing was already completed. There are some where they haven't been tested yet, and again, it goes back to that we cannot force people to be tested. We just highly recommend that they be tested. We've had instances too where other individuals in the house were also symptomatic, and so it's something as Dr. Janna mentioned that, and Dr. Nguyen, it's the elderly, those with medical conditions that they're the ones being hit hard, and to find out that other family members were mild, moderate illness prior to their high risk family member coming down with any type of symptoms, and they're the ones who are dealing with the complications, hospitalizations, or unfortunately death. But yes, we still have to continue with contact tracing, case investigation for those who have passed away.
And then, just to expand on that, so we had 35 of the 43 positive last night from contact tracing. What's the status of the 20 million contact tracing investigations you guys are doing? Because I'm waiting for these numbers to kind of wash out, but they're not.
No. Well, we still have to interview each of the household or close contacts. We do schedule them for testing, and so we do have a lot of contacts who are still negative, asymptomatic, and they're cleared to go, after they finish their quarantine. We unfortunately have some situations where one family member tested positive, is going through their isolation, their family members are being quarantined, then they get tested, they're positive, and so unfortunately the cycle continues for that household if they're unable to separate themselves. So someone may be finishing their isolation, but if a family member in the same house now tests positive, your roles are reversed. Your family member is now under isolation, you now become under quarantine. And so we've seen that in a few instances. Wow. So again, it goes back to practicing, social distancing as much as possible, separating yourself. I know it's hard with our culture, a big household, in the same house, multi-generational, but, we have our residents are very helpful. They're compliant. We have, again, success stories that may not be out there in the media that they had a positive in their house. Everybody else stayed negative because they complied with the social distancing as much as possible. They ate separate from the person. That other person stayed in their own room. They timed it where if they only had one restroom, but they disinfected after they used it, so the quarantine family members can use it and reduce the risk of exposure. So we do have those where being compliant, cooperative, they've helped us to stop the spread within their own household by following what's recommended by CDC and public health.
We've seen some of the numbers.
Others, it may have I'm sorry?
I was going to say we've seen some of the numbers increase with the military, and we get the press releases about like any NEX cases, positive cases with NEX, and I think it was a daycare center. Do you guys assist with their contact tracing at all? I know we heard about USS Frank Cable. Do you guys help?
We have a collaboration, and so like with the military members, depending on which unit or branch that they're assigned to, like if they're Anderson Air Force Base will take care of them. U.S. Naval Hospital will take care of the Navy, and if there's National Guard, we also have National Guard assisting in regards to the investigation, contact tracing. There are instances where they do ask us to take care of civilian contacts outside, and we coordinate with them, and we get the information, and we will do the interview, and we will do the scheduling for testing. So there is that collaborative effort, and Naval Hospital too is the pretty much catch-all too, that they'll take care of. You have the veterans, the retirees, and their dependents as well. But we do have that collaboration that we work with them, and they inform us if they want us to take care of certain civilian contacts and to handle the investigation as well as the testing for these individuals.
Do they take part in the contact tracing training? I know the port, I think it was Dr. Nguyen who was mentioning how Port Authority and even his staff had taken part in the training that was offered, I think, at UOG. Do you guys see the more military taking part in that, or are they just pretty much on their own?
Well, they have their own training, but I was informed that the National Guard had sent some representatives in regards to, yes, the Port Authority of Guam. Yes, they stepped up and they had people trained. Same thing with GPA. And yes, that's definitely an avenue that has helped our department. They were the ones getting the names and the contact information, looking at the work schedule. And so they provided that update to our team, which made it easier for our team. So we just had communication back and forth, the coordination to schedule these individuals for testing. And so moving forward, that's the plan with this UOG UCF training. We want to take advantage of these individuals who were trained, who go back either to private sector or Gov Guam agency, and tap on them being trained and to utilize them as our point of contact or liaison, that God forbid they have a case in their agency or their company that we can, you're our main point of contact, you're already getting the information for us, so it makes the contact tracing smoother and faster.
Mm-hmm. So right now, in terms of like agencies that have their own contact tracing teams, you can say the Port Authority and GPA?
Yeah, they've had individuals take the online course, and then they've been in communication with my team in regards to next steps, and how to move forward with testing identified employees for, that close contact. And then there are some future steps we definitely want to tighten up. GPA has reached out, and so, we want to continue to strengthen that partnership because, again, as a critical infrastructure, those guys have really taken the initiative to make sure that all their personnel are safe and to know how to monitor them and who to identify as a close contact so that they can work with us to get them identified quickly, quarantined, and to be tested as needed.
And some of the construction companies, sorry to interrupt, but some of the larger companies have even learned how to do contact tracing and investigation, and they have their own isolation and quarantine units on their sites. That's what I've been told. I haven't seen them, but I've heard that from several people.
Dr. Janna,
yes, they were actually.
Go ahead, Annette.
I'm so sorry. With like construction companies and other, especially because we're talking about congregate housing areas, prior to COVID hitting Guam, there were some planning and discussions with these construction companies just because we knew they were high risk. And so those were things that some of these companies were preparing even prior to COVID arriving on Guam. And so they've been a big help for us as well, just because they're critical to the military buildup or construction out here for Gov Guam or the private sector for residents. And so that was something that a lot of these construction companies did take the initiative and set up, okay, if we have any case in our company, this barracks will be considered isolation and other barracks is quarantine. And so they've been helpful, as Dr. Janna has mentioned.
Dr. Janna, I wanted to follow up on something you mentioned, 100%, I think you said 100% COVID GMH. Were you just talking about like the ICU?
The ICU.
Just the ICU. Is there any movement towards making GMH just 100% COVID?
That was the initial plan, and we've tried to stick to that. And it was fairly, it was working well until the census went up, and then there are some at GRMC that have to remain if they test positive until we can make room at GMH. We've run into that. I think there are maybe two, maybe at GRMC, but we try to get everyone moved over to GMH as long as there's room. And that's something I want to point out too. I've said early on, and now it makes more sense. It doesn't matter to me if there are 200,000 or 500,000 cases of COVID on Guam. Having said that, if the hospital's empty, because that means that everyone is having mild disease. The number goes away when you have the hospital saturated. And early on, I was reading in Italy where a physician was really struggling with post-traumatic stress because she said, I'm down to one ventilator. I have a 42-year-old mother in front of me with 2 children, and I've got a 62-year-old runner. I have one vent, one lives, one dies. Nobody wants to be faced with that decision, especially with the oath that we take to do no harm, then to decide life and death like that. It was just overwhelming in Italy, and I'm sure it was as challenging in New York. We don't want to get to that point. And so I don't mind how many we have out in the community as long as the hospital's okay. But that number has no relevance at all when the hospital is saturated. That is our major fire alarm. And so whatever numbers you see, the hospital is the one you really want to be looking at. So just to be clear about that, if they're mild cases, it's okay. We can handle that. But when we overwhelm our hospital facilities, we have to rethink our whole plan. And that's why the governor is trying to do what she can to put this fire out.
Right.
Because we are getting dangerously close to maxing.
So GMH ICU full, and 2 are over at GRMC. Do we know how many, I guess, ICU beds GRMC has until they're full, and then what are we going to do?
Oh, in the past you could get a straight answer, but now because we have prepared for overflow. That's a moving number. It's there's a way we can increase the capacity with personnel, with the equipment, but we don't want to have to do that. We'd like to just back off because it's just untenable what's going on, and the front line's taking a hit too. Nurses and doctors are also coming down with COVID. So better to mitigate than to prepare for the overage. But we've got capacity, but it entails mobilizing other resources, and we would like to stay within our own realms.
That sounded pretty serious.
Yeah.
Yes, they're exhausted at the hospital. They really are. It's taken a toll, and anyone who wants to open, I wish they could take a walk through the ICU and see the people on the ventilators and still say if they think it's a good plan right now.
Right.
It's a real rude awakening when. And I haven't seen it, but I work with Dr. Aguon through the PAG group, and when she joins us, it's just really exhausting with the things she says, and the difficulty of taking care of these patients because if a complication can develop, it seems to have developed on these. You can have an easy go in the unit, and you can have a tough go, and she has had tough goes with these patients. Challenging.
Right. Doc, we had we sent our condolences to the mayor of Assen this morning, and right, his daughter, the youngest, COVID fatality, just so tragic. Is there any more light that you can shed on this particular case? That as the island is just, I think with the Monomco, right, we're protecting the Monomco, but a 31-year-old, I'm still trying to just wrap
Right.
my mind around that, and it's just so tragic that,
We had a 34-year-old, 2 weeks before that,
right,
Chris?
right. So
Yeah,
what can you
I
tell us
mean,
about that?
nobody's immune. Nobody is immune, and this thing is to be feared. Um, don't let your guard down. I just socially distance, wear a mask. I mean, those things have proven effective. The long-term plan will be to have a vaccine. We're not there yet. So right now, the community we implore you to do what you need to do with the old things: hand wash, social distance, and mask. Those have proven to stop the transmission of the disease. We have to use that because our health is in our own hands, and we have to do what we can until there is a vaccine available. This is all we have. We have quarantine and those, and very effective. They're effective if you use them. And so, and we all have let our guards down. I've had some near misses, and I'm really thankful that that I didn't contract it, and I well could have. But that's all we've got for now. So the community has to do that. Protect everyone. Protect not just the elderly and the sick, the kids, everyone. Just look out for your brother, and that's what we're known to do in the islands. Is we all look out for each other.
Right.
And we have to hold hands and do that right now until there's a vaccine available. And hopefully before the end of the year, there may be one, and they're going to make sure it's safe before they launch it. So let's do what we can in the meantime.
Right. Let me bust in here, guys, and then we'll come back. I know Sabrina has a question. It's 7:59. We're KUAM FM in Agatnia, Guam. This is the link on the Breeze 93.9. Thank you so much to our viewers on KUAM TV for watching. We'll jump over to our Facebook Live feed. You can do that now or catch it on the radio. There's also an audio stream on Docomo Channel 10, and we're streaming at KUAM.com and the KUAM News app. So to our viewers on KUAM TV, thank you for watching. Hasta adios. And we're right back into it here. Again, 7:59 in progress with Dr. Janna Manglona and Annette Aguon of Public Health. Bree, question?
Yeah, I wanted to follow up on something that we had a conversation yesterday with members of the business community, and they talked about this possible new classification from essential to non-essential businesses to, is it high risk and low risk? I'm not sure if you guys have, or Dr. Janna, if you're aware of this conversation that's getting underway, and are you aware of that?
I'm not.
Not okay.
I'm not. Well, what's the gist of it?
Just so that more businesses, can open by changing it from essential to non-essential versus low risk to high risk, I guess, for exposure. And by changing it, you would be able to see more businesses open. So that whenever we go into, P Corps, changes in the P Corps, we wouldn't be where we are, complete shutdown, where we are today.
I haven't seen the conversation. I hear a lot, but looking down the path of a recovery from COVID is a little challenging when we're in the middle of a response mode. All of our efforts and energies are focused right now, and recovery time and what we do when is that remains to be seen. We have a bigger problem right now. So I don't have any comment on that. I haven't seen the trend.
What about you said you described the situation at the Guam Memorial Hospital. It's a fire, more like an inferno, it seems.
Right.
And the positivity rate, I think it's at 9% now. Hospitalizations high. Do you foresee us extending the governor extending the P Corps 1 and this lockdown past Friday?
I can't predict what she'll do, and she'll follow the lead of the. She won't follow the lead. She listens to the PAG group, and so we present recommendations. But it would probably be challenging to open with the numbers the way they are, because we're sort of maxed out at the hospital at this point. So we I can see holding steady for a period of time, whether that's days or a week. I don't know. That's just my opinion.
Right.
I certainly haven't gotten that from her, but you'd be hard pressed to open when you're in the middle of a surge like this and overwhelming our hospital.
So let me ask you, Doc, in your medical opinion, which we value highly on this show, how much longer do you think we need to be locked down in this current PCOR 1 status, in your opinion, to really put out this fire that is reaching every corner of the
watching the
island?
numbers. We're sorry to interrupt. We're watching the numbers because the minute that we can see that there's some relief in sight, we can go for it. It's difficult to predict these numbers. We didn't even see these coming. I think we had 0 in the hospital a month ago. Who knew this would happen? You know, I wouldn't have predicted I'd be saying these things a month ago. So hard to say, really hard to say. Sorry, it's just, this is shocking. But a bigger question is this our new norm? Is this the way we have to live? Are we just going to have to adjust to this virus and this is our new norm? I mean, countries everywhere are facing the same dilemmas and questions. There's no template for this. And we're all following the lead of a virus and responding to it accordingly. And so I don't know what she'll do, but it's going to take time.
Right.
We'll see if this maneuver works. If it works, then good. If it doesn't, then we've got to get a new plan to knock this down.
Right. Annette,
And I don't know what that will entail.
I was looking at the SITREP last night, and there were the JIC release, and there was a number there that caught my attention. It was 0, as in public health had run 59 tests. Right? Did you see that, Annette? I'm sure you did.
Yeah.
Yeah.
it's in the SIP form.
Ran 59 tests with no positives. What can you tell us anything about that? Because people will see that and they'll be like, "Oh." I mean, but there were 43
That's
other
for what
positives
was-
in other labs, right? But I just was wondering if you could tell us more about that.
Again, we're testing. We're recommending testing for all known contacts, and so it's good to see that there are several that are negative, or a big number that are negative. But unfortunately, yes, we're still seeing positives being reported by our partners. The numbers are lower than last week, thankfully, but it's still double digits.
Right.
And from yesterday, so we've seen it slowly go down, even from the week before. Last week was lower than the week before. This week so far is lower, and so we want to continue that trend, but we are not out of the woods by any means. We would love to go back down to 0 and single digits consistently, but again, it's a little too early to tell. We don't want anyone to let their guard down yet,
Right.
because again, it takes 2 to 14 days before symptoms appear. We have individuals who have no symptoms at all and testing positive and going around, and so that's of concern. Is we don't want to reverse course and then we get hit again with another surge and we haven't fully recovered from this one. The hospital hasn't cleared out the patients and had some breathing and recovery time, because yes, this is very taxing. I have my communication as well with GMH, and so it's just been nonstop for them, and so again, it's too early to tell. I like to see the numbers continue to go down and continue to see less positives being reported out.
Right.
But again, some of the stories that my investigators are getting from people they're interviewing is concerning. It goes back to what Dr. Manglona was saying about, social distancing and everything. But the biggest part is stay home if you're sick. Just last night, right before, one of my last investigators talking off of the day, oh yeah, my coworker was coughing right with me the last day I went to work. I'm like, oh, okay. So, you're testing positive and you're telling me the last time you went to work, someone was coughing and sneezing nonstop. So that's concerning, that people going to work knowing they're sick. You don't know if it's the flu or is it COVID. And so that just makes our job much more harder, because the exposure is still ongoing out there. You may not know you're positive because you didn't get tested yet, but then now we're backtracking when we find out days later that, yeah, you are positive, and now we have to deal with household and your work contacts because you didn't listen about staying home, covering your cough, wearing your mask, social distancing. And so it's
That's
just
a good
it's just
point.
continuing like that.
Yeah.
You know, we're I think this is week 3, right, Chris? Week 3 in the stay-at-home order. This is week 3. At what point can we tell whether or not, I guess, the stay-at-home order is working? Is it too soon to tell? Is that what you said,
It's
Annette?
too
It's
soon.
too
Yes,
soon?
I agree with Annette. It's too soon.
Okay.
We need a little more time to watch these numbers, and we're watching the overall numbers. And Dr. Cabrera is gracious enough to keep those tracked, and then our epi team the same. And then we've got to watch the hospital. Again, I don't care about the numbers. I care about the hospital.
Yeah.
If we're at 0 in the hospital, that means everyone is doing okay. But when we go from a death, a total of 5 to what are we, 19 now? It's and they've all come in the past few weeks. The bulk of them, until we see that go down, you all will know. You will see the trend yourself. And when you start feeling like, we've got breathing room, that's pretty much where we'll feel the same. Mm-hmm. And as far as testing goes, everyone knows we had a major backlog when we tried to not turn anyone away, and Annette can comment on this a little bit more. So now, will we still be doing testing? Yes, but we've decided to control it to limit it to the capacity of the lab, so that we don't overshoot their capacity to do timely testing and timely notification. And then we're doing targeted testing for contacts, and so those are the 2 paths we're using for testing at this point in time.
Okay, so hospitalizations, the number to watch then, and it doesn't look so good. So the likelihood of extending this stay-at-home order,
Unseen damage,
it's pretty likely.
The result of the COVID. I mean, that people don't see that. Mm-hmm. So
yeah, we've been talking about how serious, it is at GMH. Yeah. I mean, every time we talk to Lillian, it's just so heartbreaking. So,
right. Yeah. And just to emphasize, like Dr. Manglona mentioned prior, this disease knows no boundary. It doesn't discriminate. And it's really concerning because we seeing some of the reports from GMH, different ages going into the ER, different individuals, age, background, or health condition, but shortness of breath, the fever, the different symptoms that they're experiencing, but just the fact that it's a wide age range is very concerning. And so people, especially those who feel young, that are young and feel healthy, please don't take it for granted. And again, it like Dr. Wen mentioned, you may be okay, but how about your mom or your dad or grandma, grandpa, or a family member who has a medical condition? That's who you can be protecting, even if you're perfectly fine and healthy and you work out. But it's really those who have weakened immune system that we are very concerned for. And then the numbers coming in from GMH, it's a wide age range, and it's just very disheartening that yes, our brothers and sisters at GMH are overwhelmed. They are just I don't know, they're just amazing for what they're dealing with and pushing through. But again, it is just to put that word out. It's any age. Mm-hmm. You should be concerned.
Yeah. And Annette, I know young people who work out all the time, very healthy, were in the ICU with COVID. So I mean,
COVID doesn't care.
Yeah, it's not just their elder relatives. Care. Yeah.
I want to point out something else too. I don't know if you can see that. It's a little graph, and negative, positive, negative. I've had some people say, hey, I tested positive and I went to a different clinic, or I tested positive. I went to a different clinic and I was negative. I think I'm not going to go back to that other clinic. And I said, hold on, that's a natural course. If you read the book, and if COVID does what it's supposed to do, if you catch it early in its cycle, you will not have enough virus load to test positive. So you'll be negative. And then if we catch it in the sweet spot in the middle of the curve, you will be positive. And then shortly after, you should go back to negative again. So please know that you can believe your test. That's just the natural course of it. Now, some of the people out here don't test negative, and they come up positive, and it just stays positive for a while, because that's what I use your word over and over. The crumbs
Right.
that are left behind may still be around, and you'll test positive. So there's no evidence to show that you're still infectious, but it can happen, but we don't get as excited about that as we did early on.
Right.
We kept someone in isolation for like 60 some days, I
Right,
think,
yeah.
because he kept testing positive.
Yeah.
But then they came out and said, hey, the studies are showing it's not infection, it's not a reinfection, they're not infectious. They can go ahead, but it's just the machine picks up the leftover virus,
Right.
and it doesn't know any better. So just to know that it's not the clinic, it's actually the COVID.
Yeah.
So
I guess before,
and one day can make a difference. One day you can be positive, negative within a day's time. It depends on where you catch it in the curve.
Wow.
and so I guess before we let you go, where are we with the serology study? Or I think we kind of mentioned that a while back.
I'll let Annette talk about serology study and surveillance, but I want to say serology testing is not advised or recommended by the CDC for individual cases or making clinical decisions. It's not a very sensitive test. A lot of bugs in that one, and it's not used for clinical guidance at all. For example, you may have COVID and then your serology may be negative. No surprise. That's why they're advising against using it for those types of purposes. So please don't get a serology test.
Mm-hmm.
They don't count. They don't clear you. They don't anything you. If you do have antibodies, okay, but it doesn't tell you. Some don't tell you the early antibodies to know if you're acutely infected versus old antibodies like you had it 2 months ago. We don't need that. I mean, you really don't need it. Maybe somebody wants to do it for academic reasons, but it does not clear you. Please do not get one.
Right.
Please save your money.
Correct. Yes, serology is only for surveillance right now. And so that discussion we've mentioned about a project that is still in the works with University of Guam, a partnership between Public Health and University of Guam for surveillance purposes. However, it still has to run its course because we are working with the university. It would have to go through the institute, the IRB approval, Institution Review Board, to make sure everything is okay. And so then that will be planned for launch later on down the road. But again, yes, it's for surveillance.
Okay.
It's not for diagnosis.
Yeah, no, I thought
in
you had mentioned
actuality-
there was a study that was in the works. I
Yeah.
just wanted to get an update and see if that was
Right.
if there's been any movement.
Right. And part of the plan for that serology study would to actually go back and test the known positives. Because then we want to see too how long are the antibodies still in your system, because that's something that's of interest around the world, is how long will someone be immune. So again, like Dr. Janna mentioned, this is not for diagnosis. It's just to see for surveillance purposes. And again, it's not what we're using in regards to testing you to find out if you are positive or negative for coronavirus.
Right.
All right.
And it's sort of academic right now. Surveillance, what do we mean by that? If we can study 50 people and do serology on them and say, half of them formed antibodies. Good to know. Are they protective? We don't know. Right now, we think they may be protected for about 3 months. We don't know why some form them, some don't. It's just a head scratcher right now, where we look at it and we get a piece of the puzzle and go, look at this. It doesn't mean anything clinically at this point in time. And we're finding now that some cases, I think Nevada, Hong Kong, we mentioned this before, Chris, somebody came back and had a new infection with a little twist on the original strain. So will you form antibodies to that? I don't know. It's very academic right now. So if you think you're going to get somewhere with that, like a clearance or rule out disease, we're not there yet. So save your money for now. Hold that thought. Maybe next year it will be different, but at this point, no.
Closing thoughts, ladies. But thank you again for your time. You spent nearly an hour with us. We appreciate
Yeah,
it.
thank you.
Brought a lot of insight. So I guess
Thanks for giving us a platform. We appreciate it.
Thank you.
Yes.
so last word
Yes,
to the
stay safe, Guam. Yeah, just please stay safe, Guam. Wear your mask. Stay
Your
home,
health is in
please,
your
if you're
hands.
sick.
Yes,
That's right,
Your health
and we
is
need
in
your help.
hands. Yep, we need the
Exactly.
community to help us.
All right.
Thank you.
Thank you, ladies.
Be
Thank
safe.
you.
Stay
Stay
safe.
safe.
Stay safe.
Y'all come back, you
Have a
hear?
good day.
Bye, y'all.
All right, there you go. Dr. Janna Manglona and Annette Aguon from the Department of Public Health Social Services. Again, I got to give my thank you to the acting director, Art St. Augustine, who's
Yes.
is confirmation hearing tomorrow?
We're still having a confirmation.
I don't know. I thought I saw
Probably,
something like
maybe.
that.
I
Yeah.
know there's an oversight hearing.
Right.
For
So
Parks and Recs.
thank you very much to the director for giving us the access to those, and you got to have that public health presence in the midst of a
Yes.
public health pandemic. It's 8:17. We're coming back with the superintendent of the Guam Department of Education, John Fernandez, next right here on the link. It's the Breeze 93.9, proudly brought to you by Calvo Enterprises, IT&E